Okay, there we go. Alrighty. Okay, so let's talk about visual impairments. And we have to get through how we see so that we can talk about visual impairments. It says visual impairments are one of the most common forms of sensory losses affecting patients who have hemiplegia. The lesions resulting from a stroke can affect the eye, which is the base level. It can affect the optic radiation. We'll take you into that. And then the visual cortex, that's the part in the occipital lobe of the brain. And it can affect either reception of visual information, transmission, and appreciation of any visual array, things that we're seeing visually that they don't have context for. They're encountered by patients with hemiplegia. The ones encountered by patients with this include poor eyesight altogether, so they may lose the ability to have clarity of sight, so they may have fuzzy or hazy visual deficits. They may have diplopia, which is another word for double vision. So it's a fancy word for double vision, diplopia. Homonymous hemianopia. That's what we're going to teach you about today. Homonymous hemianopia. Or damage to the visual cortex or the retina. Okay. Awareness of these is important so as to not confuse them with visual perceptual deficits when you're doing your treatments or therapeutic intervention. Okay, so the critical nature of the basic visual skills in forming a basis for high level visual perception is highlighted by Warren. We're not going to go crazy into that. One thing that he pointed out was something about having visual attention, focusing on one aspect of the environment while ignoring others. So you have to have visual attention. Driving just keeps coming to mind because you have to be able to focus on the road while blocking out all of the peripheral stuff going on outside of the car. You can't be staring at the trees and the sun and the moon and how the light hits the top of the tree and still be focused on the road. You got to have visual attention. Visual scanning is something that we use every day. Your eyes do this all the time so that you don't look down on the ground. So when you're walking, you're able to keep your head up straight because your eyes have already scanned the area before your feet get there. So you're not looking down nervous you're going to trip over something because your eyes have already scanned the environment and know what is or is not there. So you already know what to do instinctively. So that's a type of visual scanning. Pattern recognition, meaning you see things in patterns. You're able to identify that that's a pattern or not a pattern. Okay. It says these skills, along with memory, are required to facilitate the highest level of visual skill called visual cognition. Visual cognition. Okay. Impairments of oculomotor control or the control of eye movement. So there's 3 or 4 cranial nerves that deal with eye movements are common following a CVA. Poor visual acuity, meaning they don't have clear vision. They can't see things well. Things look blurry or out of focus. That's poor acuity. Is another finding of patients with stroke and brain injuries, even in the absence of other problems. Diplopia or double vision is often present following a brain injury. The patient sees 2 of the entire environment. It's usually the result of a defective function of the extraocular muscles in which both eyes are used but not in conjunction. Treatment is usually going to be done to strengthen the eye muscle. In addition, the patient is instructed to wear an eye patch on alternate eyes until the condition clears. Really, what you want them to do is patch the strong eye. So I know that sounds weird. You're thinking, no, we should patch the weaker eye and that'll help it. Really, it won't. So if I have double vision problems from a stroke, then what I need is for you to patch my strong eye. So if I have if I have a right-sided stroke and that causes me left-sided deficits with left visual acuity problems, I would need you to patch my right eye. And what happens is by patching my right eye, you force the muscles of my left eye to get stronger. It's almost like constraint-induced movement therapy for the eye. So it's really cool. You'll patch the strong eye and force them to strengthen the muscles of the weaker eye, and then over time, and it usually will clear in about a week or two, over the course of time, that eye will get stronger and you can remove the patch. And they can remove it throughout the day as well, but you want them to keep the patch on for an extended period of time so that the eye will get stronger. Okay? Anybody ever see that clinically when you were there? You'll probably see it once you get there. People have eye patches on the side that's not problematic. So that's why you'll see that. If the condition doesn't clear, then they'll need to see an optometrist, and they'll use prisms to help with that. Way outside of our skill set there. Visual field deficits are probably the most common visual defect affecting patients with hemiplegia, and they occur most frequently following damage to the middle cerebral artery. Just middle cerebral artery. The diagnostic term for the deficit is homonymous hemianopia. The frequency of hemianopia following a right hemisphere stroke is about 17%. And it correlates between the presence of visual field deficits and visual neglect. So patients who will have neglect on one side. Okay, left neglect. All right, so that leads us to figure 27.3, and we'll start talking about how your eyes see, because your eyes see a very specific way. Okay, so let's talk about the eye. Well, let me do this first. Let me do a video so you can see it, and then we'll come back and I will teach it after you see it.
Hello, in this video we're going to look at the pathway of vision, and we also will look at what happens when there are lesions that occur along this pathway and how it affects our vision. So here is the occipital lobe, the eyeball, optic nerve, optic chiasm, lateral geniculate body, and optic tract, also known as the genico-cacrine tract. Here are our visual fields. We are looking at this whole visual pathway, from the top. So the blue nerve on the left side here will pick up the left nasal field and will carry this visual information to the lateral geniculate body, where it will synapse with another nerve. And this other nerve will then carry this information to the occipital lobe. The blue nerve on the right eyeball here will capture images from the right temporal field and will carry this information down the optic nerve and will cross over at the optic chiasm and synapse with the neurons of the left lateral geniculate body. The nerves will then carry the information to the occipital lobe. This orange optic nerve on the left eyeball here will capture images from the left temporal visual field and cross over at the optic chiasm and synapse at the right lateral geniculate body, where it will relay the information to the occipital, to the optic tract, which then will bring it to the occipital lobe. Now, similarly, the orange optic nerve of the right eye will capture the image from the right nasal visual field. It will not cross over, but will remain, will relay this information, down to the lateral geniculate body, and then it will synapse with other nerves along the optic tract and then down to the occipital lobe. I hope this pathway makes sense.
In this lesson, I'd like to look back at a revised version of my optic pathway.
Okay, so let's talk about your eyes and how they see. Old sailor went to sea, sea, sea. Okay, so this will be your eye, and this will be your eye. And then we'll put that at the top like the eyeball. And you're looking out. So let's say we're looking out. So I'm going to draw a field here and a field here. Or I don't want to draw fields. Fields are going to confuse you. Okay, so when we look at vision, our abilities to see, there are very specific things that go on. So let me see here. Let me draw a little bit. Draw them up. So yeah, let me draw them up this way. So eyes. Okay. And then your eyes have tracks. Okay, and there's a track that's coming from here to here. Track coming from there. Track coming from there. And this will be this portion in the true rear is going to be known as your occipital lobe of your brain. So let's start labeling parts. So this here is the occipital lobe, which processes visual information. So the back side of your brain, your occipital lobe, is responsible for processing things that you see, visual information. All visual information is processed by the occipital lobe. The goal of your eyes is to get information from what you see from your eyes to the occipital lobe so it can process it. So the goal of vision get info from your eye to the occipital lobe for processing. So that's what we're trying to do. Trying to get information from your eyes, things that you're able to see and perceive, to the occipital lobe for processing. You have to get it to the brain for processing. Okay, so we have there are rods and cones in our eyes. So the way we will do that is we will say their job. We're not going to talk about what's happening in the eye with the rods and cones. We're going to talk about how they see. So we're going to pick up from the first part is going to be the optic nerve. So optic nerve. And so the blue part here, well, let's see here. I don't want to do all blue. Let's do this. So let's say visual input is coming into your eye. Okay, so you have a left eye, so I'm gonna put left eye, I'm gonna put right eye. I have a left eye, right eye. Okay, so my left eye has two specific things that is picking up. It has lateral cones and it has medial cones. So this one will be a lateral cone or lateral rod and cone. You can just put lateral visual perception, and then this is medial. And then my right eye has the same thing. It has lateral and medial cones and rods. Oh no, that's not, that should be medial. Medial, lateral. And this will be your nose. So your nose is in the middle. Just make it make sense. So, nose. Awkward face. That was your eyes. That's weird. Okay, so your lateral rods and cones, so they'll be on the outer portion. Their job is to see nasally. So their job is to see nasal, vision coming towards your nose. So your lateral rod and cone of your left eye will see nasally. So they're going to see, they start on the lateral side, but they see medial. So they're going to see medial. They start lateral, but they see medial. The medial cones of your eye will start medial, but they will see lateral or peripheral. That's a term that you really want to use. So your medial rods and cones job is to see peripheral, your peripheral vision. So if you are looking straight ahead, the stuff you see out of the corner of your eye. So you can test your peripheral vision by taking your hands, putting up two fingers like this, go as wide as you can. You shouldn't be able to see your fingers, and then slowly start to work your hands towards the midline, and when you can see your fingers there, that lets you know where your peripheral vision is. So if you have really close hands, you have very poor peripheral vision. Anybody? Was that? I was like, oh my, we have a lot of work to do. Send you to the optometrist. Okay, so same thing happens with my right eye. My medial cones are going to see lateral or peripheral, and my lateral cones are going to see nasal. Okay, so that gives me what we would call a visual field. That gives me what we would call a visual field. That's what you're seeing here. You have a visual field. So two eyes are responsible for seeing things nasal and seeing things peripheral. So I have central vision, nasal, and I have peripheral vision, lateral. Full visual spectrum. Make sense? Nobody's lost there. You're okay with that? We'll make this thing work. So that's what that picture is showing there. You have a tree and a car, both in your central vision, and it's showing you how that works. And so what happens with our vision is we end up with each eye providing, well, with each visual field provided by both eyes. So my abilities to see to my left comes from the abilities to see what's going on the left-hand side comes from my left eye medial rod and cone and my right eye lateral rod and cone. Can you see that? That's visual to the left. Vision to the right is the exact opposite. And then they cross over. Okay? So, visual information travels into the eye through the rods and cones to the retina. You don't have to know that part. But ultimately, all visual information is going to be sent to your optic nerve. Your optic nerve. So that's ultimately where we're trying to get vision to. We're trying to get vision to our optic nerve. So this is a good picture here showing the information. Vision is coming in and it's going to be transmitted ultimately to our optic nerve. Optic nerve. Okay? So optic nerve is going to pick up vision right behind the eye. So the eye transmits vision from rods and cones of the retina to the optic nerve. And the optic nerve is right in here. And so this is the retina with rods and cone inside of the eye. It's the same way. Retina, rods and cone. And then right in here is the optic nerve. Okay? So, the eye's job, pull information in, put it on my retina, they discern it, they're transmitting information directly from that retina to my rods and cones, to my optic nerve. Okay, so the way the optic nerve works, my lateral rods and cones will always travel in the same plane. Okay? Yeah, this is the one I want to see. Okay? So my lateral rods and cones will travel in the same plane. They're going to travel from the optic nerve down to the optic tract. So this is optic nerve here. Then once we get here, this becomes the optic tract. And then beyond that, it's going to travel through my optic radiations or geniculate body. So we'll just call them optic radiations. To my occipital lobe. Okay? So my lateral rods and cones that pull vision will travel directly from my eyeball into my optic nerve, through my optic tract, past the optic radiations, into the occipital lobe. Okay. Same thing will happen with my right eye. The optic information from the lateral rods and cone. It's going to travel the same way. Follow same as left. Okay. So the lateral are going to travel from The lateral rods and cone, which see centrally, are going to travel directly from my eye, from my retina, into my optic nerve, all the way through the optic tract, all the way into ultimately the into the occipital lobe, processed by my brain. So the lateral cones, which see nasally, that's the way you really want to deal with this. The lateral cones, rods and cones of my eye, which see nasally, they're lateral in their position. They function to see nasally, and they are going to travel all the way direct. We'll say they travel direct from my eye or my retina to my occipital lobe, never interrupted. My medial cones are going to do something interesting. Right here in the center of this pathway is going to be something called the optic chiasm. So right in here in the center is called the optic chiasm. So this thing is the optic chiasm. C-H-I-A, there should be an A. Optic chiasm. Right in the middle of the two. Optic chiasm. Okay? And here, if you look at a brain and you flipped it upside down, the chiasm is right here in the middle here, right by the pituitary glands. Okay, so the optic chiasm right in the middle. My medial rods and cones are going to do something really cool. They're going to enter my optic nerve, and instead of traveling direct to the occipital lobe, they're going to go and cross through my optic chiasm. Sounds like anterior lateral spinal thalamic. Crosses to the other side. It's going to cross to the other side, join with the cones and rods from my right eye, which the lateral rods and cones of my right eye have already started traveling that way. They're going to join with it and then continue down towards the occipital lobe. So my medial rods and cones of my left eye will be communicated to my occipital lobe on the right side. Still passing through the same structures, it's just doing it in a different way. Same thing happens with my medial rods and cones for my right eye. It's going to pass through my chiasm, and it's going to then join with my left eye's rods and cones, and it's going to then go to my occipital lobe. Okay. So it's important that you get the understanding there, because that's going to help us understand what happens when we have damage to this, because we're about to damage these and cause some dysfunctions. Okay, so any questions there? So the way the eye sees, you have rods and cones, lateral, medial, and they're responsible for seeing the opposite direction from where they're positioned in the eye. Medial sees lateral or peripheral. Lateral sees medial or nasal. That information is communicated to the occipital lobe via the optic nerve originally, then it'll be the optic tract, and then ultimately it'll reach the occipital lobe. Okay, and so that's the way vision works. Okay, Anybody, it's going to take some time to review these. This won't be the only time you'll see it. Okay, so let's put in some dysfunctions, because that's what's going to be fun. Alrighty, do I have another color marker? Red, blue, green, yellow. Nope, those are permanent. Ooh, definitely don't want to run on there with that. That'll get me in trouble. Okay. Yeah, well, I can use that one since I only used it for the chiasm. Okay, so let's look at my right eye. So I'll say I'm gonna start having deficits in my right eye. Okay, so let me use the black marker because it'll make more sense. Okay, so let's say I have damage to my right optic nerve. So I'm going to damage it right here. So I have damage to the right optic nerve. If I have damage to the right optic nerve, then I take out all communication of visual information to my occipital lobe. So there is no more communication for that information, and it's before it crosses. So because it's before it crosses and I'm taking out all the visual information, the damage I will see is blindness in that eye. So if I injure my right optic nerve, or my left optic nerve for that fact, I damage it. So I have a penetrating wound, penetrating injury to my eye, and it takes out my optic nerve. Or I have a blood vessel explode in that area, and it takes out my optic nerve. I'm going to have blindness in my right eye. So if we take out this optic nerve, or let's see here, let's see if it's drawn better. Let's go up to the other one. Let's use this one because this one is more similar to what we're dealing with. Okay. Okay. So if I take out this right optic nerve here, then I'm going to lose all visual communication with this right eye, and I'm going to have blindness in my right eye. Okay. Alrighty. If I damage the optic chiasm, I damage the optic chiasm. So I have a pituitary tumor, something in my brain. So I have some kind of pituitary tumor, something going on. I damage the optic chiasm. In the chiasm is where my medial rods and cones that carry peripheral or temporal vision, that's what I'm injuring. My medial rods and cones, but they carry peripheral or temporal vision. So if I take out the chiasm, then I take out both sides of my abilities to see peripherally. So I end up with what we call bitemporal hemianopia. Hemianopia is just a fancy word for complete vision loss. So when you see the word hemianopia, Think vision loss. Okay. Or visual field deficit. So bitemporal hemianopia, if I take out the chiasm, because I'm losing my peripheral vision. Or another term for this that you probably have heard is I will have tunnel vision. That's a common term you'll hear. So imagine, take both of your hands and put them on the side of your head like this. Or let's see here, I'm trying to see how we can do it. Yeah, like a blocker. And see how much information you can see now. Do you see anything peripherally? No. If you wanted to see what was going on in the corner, how would you have to see it? You have to turn your whole head. So people who have tunnel vision lack peripheral vision. And so they have to move their head and neck or their bodies to see things peripherally. Make sense? So I have bitemporal hemianopia or tunneled vision. Tunneled vision. Okay. The third place I can have damage is I can damage the optic chiasm. No, not the optic chiasm. I can damage once it passes through the optic chiasm, and now I'm damaging the optic tract. So just like you have the dorsal columns medial lemniscus tract, you have the anterolateral spinal thalamic tract, you have the corticospinal tract, vestibulospinal tract. You can damage the optic tract. So I can have damage to the tract. So let's say here, this is the optic tract. I'm going to take out the optic tract. So I'm damaging the optic tract. The communication from the optic nerve, so just like we're getting information from radial nerve or median nerve or femoral nerve into the tract, and then it carries it to the brain. The optic nerve, cranial nerve 2, carries information to the optic tract. And so I can damage the optic tract. So now when I think about the optic tract, I think about what's being carried by the tract. The right tract is carrying my lateral rods and cones, which see nasally. So I'm going to take out nasal vision from my right eye, but it's also carrying my medial cone from my left eye, which sees temporal. So I'm going to end up with what we would call homonymous hemianopia. Or I'm going to lose visual field, vision, and a field of view. So I'm taking out everything that sees left. I'm taking out lateral that see nasal, and I'm taking out medial that sees peripheral or temporal. So I'm going to end up with a homonymous, I can't even spell it, hemianopia. I'm just going to abbreviate it. Yeah, hemianopia. I always misspell homonymous. But I'm going to end up with the homonymous hemianopia. I'm going to have a visual field cut where I don't have Temporal, I don't have nasal vision in my right eye, and I don't have, so I lack nasal vision in my right eye and temporal vision in my left eye. So I'm losing nasal in my right, so my lateral cone see nasal, so I'm taking out nasal in my right, temporal in my left. So nasal is going from my right, temporal is going from my left. So I'm taking out both of those. I have what's called a homonymous hemianopia. Okay. And the cool thing is, the last place we will talk about after the optic tract is going to be the occipital lobe, and it produces the exact same thing, a homonymous hemianopia. It just has central sparing. Okay. Okay. So this one kind of, all of these kind of give you functional ways of seeing this. Okay. And so let's see what that looks like.
A homonymous hemanopsia is a loss of one half of the visual field in both eyes. This is due to the way nerve fibers cross as they pass to the brain. If the right posterior hemisphere of the brain is injured through stroke, tumor, or other traumatic brain injury, the result may be a loss of visual field on the left side. The patient does not see black. The loss is a void in the vision. The patient's brain may fill in the area of field loss perceptually in a way that roughly matches the color and brightness of the rest of the visual environment. To understand how a homonymous hemanopsia occurs, we need to look at the pathway of the vision from the eye to the brain. Visual information must pass from the eyes to the occipital lobe at the back of the brain. If we place yellow and red squares in front of the patient, we can see how the yellow image on the left from both eyes passes to the right side of the brain. Conversely, the red image from the right side passes from both eyes to the left side of the brain. The brain puts both of these images into the yellow-red squares. A hemanopsia can severely impact a patient's life.
When I had my stroke, one of the problems I had was I could not see on the left side, and which caused lots of problems. I would run into things. I used to run into the handicap signs. I had trouble walking across the room without falling, and my children's toys, I could not see to walk around them.
Today, we have many treatment options to help patients with homonymous hemanopsias. This website is dedicated to helping patients learn about treatment options.
Mm. Wow. That is interesting on the frontal lobe. So that's taking out, optic nerve travels through the frontal lobe going back to the back of the head. So it probably has something to do with the optic nerve, like some optic neuralgia. So swelling around that. That is crazy. How's she doing with it? Gotcha. That would be tough to, go from being visually astute to not having vision would be really hard as a person. All right, take 5. Stretch your brains since they have been stretched this morning. Okay. Alrighty. Okay. So that's visual field. Now let's talk about why it's important. I have to teach you all that just to talk about why it's important. Okay. So it says figure 27.3 demonstrates the normal function of visual fields in which the left side of the environment is perceived by the nasal retina of the left eye and the temporal retina of the right eye. And the right side, which has the car, is by the nasal retina of the right eye and the temporal of the left. The lesion producing homonymous hemianopia interrupts inflow to the optic pathways on one side of the brain. This produces a loss of the outer half of the visual field of one eye, the inner field of the other eye. So we cut a whole visual field out. The result is loss of incoming information from half of the environment, contralateral to the side of the lesion. So it's going to be on the opposite side of the lesion. Thus, the loss of the left half of the visual field accompanies left hemiplegia, and loss of right visual field accompanies right hemiplegia. Okay. Zhang noted that there's spontaneous recovery of this in 40% of the cases. So sometimes this will start to improve itself. The presence of visual field cut may inhibit performances of daily activity. The patient is usually unaware of the condition and does not automatically compensate by turning their head unless specifically instructed. So they won't even notice that the visual field is deficit. So you may be, hopefully you won't be the only person that will have noticed it, but it is good just to check it. If you're dealing with a patient with a stroke or traumatic brain, it's always good to check it. An easy way to check it is to have them close one eye and tell you what they see out of the other eye. How far can they see nasally? So if you should be able to close one eye and still see things nasally. So I can see as far as, if I just keep my eyes straight, nasally I can see the back door, the paper on the back door, and temporally I can see, honestly, this way toward Alexis. And then you close the other eye and see what they can see. And so you're looking for visual field deficits. Yes, ma'am? Mm-hmm. So his was a bitemporal hemianopia. So his was peripheral vision deficit. So what she was trying to do was expand his peripheral vision. Start central and then move it further out so that you can expand peripheral. So it was either unilateral peripheral loss or bitemporal hemianopia. So loss of the temporal vision. But yeah, that's a cool thing to do. Some cool ways you can treat this. And you'll see this clinically. So there'll be some cool ways you can see it. So the book says one of the dangers in this condition is street crossing. So being able to look both ways. So if they only look one way, they don't see a car coming, they can get smashed or mashed. That's dangerous. Reading a newspaper is another deficit. You can't, or reading all together. If you're only looking at one half of the page, you can have a visual field cut that'll mess that up. Okay. So it says, because homonymous hemianopia's prevalence, it is essential that we determine whether the condition is present or not. There's a number of procedures that we can use. In confrontation method, the patient sits opposite the therapist and instructed to maintain his or her gaze on the therapist's nose. The therapist slowly brings a target, such as the finger or pen, into the patient's field of view simultaneously or alternately from the right or the left. They're instructed to indicate when and where they see the target. So you're sitting facing them, you'll have your arms out wide where they can't see, and then you can either slowly move in one, or you can do both to make sure that they have peripheral and and central vision, and then you can do one versus the other one. And if there's one way out there and one is in another place, that's something they can do. To help them compensate, they should be made aware of the deficit and instructed to turn their head to the affected side. They usually require constant reminders at first, which may taper off with practice. Early in therapy, items like utensils, writing, things like that should be placed where the patient is most apt to see them on their less affected side. Then we can progressively move them to the midline and then to the more affected side. Okay. Nursing staff should be made aware of the condition and requested to place essential bedside needs, such as the phone, tissues, or other things inside of their intact visual field early on. External cues can be employed, using a red line to draw on the side of a page to show them something is not seen, red tape on the floor or on a mat or on parallel bars to attract the patient to scan to that side. They should be taught to look for these cues. Okay. So then it also talks about how you can do visual scanning. It says scanning can be tested by sitting opposite the patient, holding a pencil with a colorful topper 18 inches in front of the patient's eye. Slowly move it horizontally, then vertically, and then diagonally. Repeat each direction 2 or 3 times. Note the smoothness of the eyes, the gaze. See if they can scan from where you are without moving their head to see. Eye gaze. Okay. So those are ways we can assess for impairments. Okay. Alrighty. So treatment approaches. So there are different ones that really talk about the same stuff. We're not going to get into the approaches. We deal more with the patient and family and caregiver education. Education for the patient, family, and caregivers will be essential. The patient and caregiver should understand why it's inadvisable or impossible for them to do something safely or independently, or why it must be done in a specific way. Explaining the reason why the patient behaves in a particular way may reduce the likelihood for inappropriate expectations. Feedback is essential. The patient's own feedback may be inaccurate on into their dysfunction. Thus, they may be unaware that a task has not been accomplished or that it has not been performed in the safest or most efficient manner. Feedback from us will either use knowledge of results or knowledge of performance to let them know the manner in which the task should be completed. Okay, so that's good stuff. Alrighty, so now that leads us into attention deficits. I think we can get through that by Monday or Tuesday. All right, what time is it? Let me see here. Alrighty. I won't be a wiener. Go on break. See you Monday. Monday, yes. I didn't screw that one up. Not this Monday, a week from Monday. Yeah. Have fun. No, if you show up this Monday, it'll just be you and Jesus.